A little louder. I don't know. Talk.
Is this louder?
Yeah.
Okay, cool. All right, so let's get started. We're going to read on Instagram. I apologize if you can tell from scrubs I'm on surgery, so I couldn't put as much time into making sure this lined up with the current lectures as I normally do, so I tried to, but it was not as good. I don't know. You can get a refund. Okay, so yesterday was repro. So the main points is this meiosis 2 happens at puberty. That's really the big point of that. Okay. So hormone review, testosterone, keeps Wolffian ducts in male, causes introducing development of epididymis, vas deferens, seminal vesicles. One thing to remember is that it directly affects a bunch of organs, like, even in the adult, so like the liver, red blood cells, why men have higher muscle mass, abdominal fat, so fat distribution, skeleton, and makes the voice deeper. But mainly in the testes. An anti-malarian hormone degrades the malaria duct, that should be pretty self-explanatory. DHT is from testosterone, and that is the penis, scrotum, urethra, and prostate, so it does all the external stuff, which is all, pretty emphasized in the lecture. GnRH increases FSH, LH, so those are gonadotropins. So FSH in males is going to stimulate the Sertoli cells, sperm development, and females is going to cause the granulosa cells to release estrogen. LH in males, LH, Leydig, LL, secrete testosterone, and then in females, theca cells release androstenedione, which makes estrogen. So again, pretty similar, pretty analogous functions. HCG, maintain the corpus luteum for the first trimester, so this is what pregnancy tests are based off of. And it's got the alpha and the beta subunit. One thing to remember, so again, like the betas for pregnancy testing, the alpha subunit is really similar to FSH, LH, and TSH, which is why if you have an increase in one type of hormone, you can get symptoms of having an increase in other things. So why you can get like hyperthyroid if you have an increase in gonadotropins. Because your body can't really tell the difference very well sometimes. Okay, so then inhibin is going to inhibit FSH in the male Sertoli cells. Estrogen gives you all the lady parts, and also causes the growth of the follicle and the endometrium. Progesterone is going to stimulate endometrial gland secretions, so it's what keeps the endometrium nice and ready for some baby parts. Maintains pregnancy and inhibits FSH and LH. Okay, so some of the genetic diseases that we talked about: Turner syndrome, X chromosome, inactivated the germ cells. So, but you're always going to get shield chest, side space nipples. There also there's like a weird thing. Part of that is like the neck is kind of there's like extra skin on the neck, so it goes out a little bit. And then do you guys remember what the cardiovascular association is with that? So like coarctation of the aorta is one. That's like the high yield step stuff. It'll be like pretty obvious that it's nutrition, but you need to know those associations. So coarctation of the aorta is a huge one. So Klinefelter's XXY, you can know spermatogenesis. So this is most commonly going to be diagnosed when a man is getting worked up for infertility. Again, something you need to be able to recognize in a question. Commons, aplated olfactory lobes, and improper migration lead to low GnRH. So they have no sense of smell, and they're infertile. And these are men. And then male pseudohermaphroditism, testes present with some or all of the female tracking external genitalia versus female. So whether it's male or female is based on testes or ovaries. So it's whichever it is. Okay, definitely gotta know the menstrual cycle and the respective changes in hormones as it goes. So first you have the proliferative. Well, it's not first here. We have the proliferative phase. This is going to determine the length of the menstrual cycle, so this is the one that's most variable, which seems like a stupid extra fact, but it's something that's weirdly frequently asked. So you're going to get the increasing estrogen throughout this phase, decreasing FSH, and the end of this phase is marked by that LH surge. And if you guys remember Dr. Pack's thing with like the feedback, the LH surge is what breaks that positive feedback loop. Okay, so ovulation, you're going to get that spike in FSH and LH. You're going to get an estrogen peak, and the LH is what causes ovulation. So ovulation is just the release of that egg. In secretory, it's typically 14 days. Spike spike in progesterone to maintain the endometrium, maybe support implantation, we'll see. And then that's obviously when you don't get pregnant, that's what leads to menses. All right, so follicles, unruptured Jacq follicles have clear serous fluid. Corpus luteum follicles can hemorrhage. PCOS is also a super highly tested thing. So it's polycystic ovarian syndrome. So if you do an ultrasound, you're going to see cysts all through the ovaries, and you're going to have increased increased LH and low FSH. It's usually 2 to 1. So you're going to get increased androgen production. Follicles won't develop, and so they won't go through the whole cycle they're supposed to, so they'll just turn into cysts instead. So the clinical picture of this is going to be, of course, is going to be an obese young woman with infertility, oligomenorrhea, insulin resistance, hirsutism. Do you guys remember the treatment for this? So like weight loss is first line, and then they have a problem with their hormonal balance, right? So you can do like some hormonal treatment. And then the other thing that's like kind of random, you can use spironolactone or metformin. And metformin is to prevent diabetes, because diabetes is really highly associated with this. And then spironolactone is like the first line medical treatment. All right, so let's talk about some ovarian tumors. So surface epithelial tumors are the most common. So you have the two main types of serous, which is more common bilaterally. So the benign serous is the cyst adenoma, which can be smooth, glistening walls, fluid-filled, single epithelium layer with tall columnar cells. So that's what this picture is. These tall columnar cells, they look super non-cancerous. They look pretty okay. And then and then the malignant one is carcinoma, which is papillary structures, sonoma bodies, nests, and cords of cells. So you're going to get like much less organization in that cell structure. And then mucinous, you're going to get more common unilaterally, and obviously like this is filled with mucin, so it's going to look super gross. And again, you're going to get a single row, uniform, columnar cells. And then for the carcinoma, confluent group, solid and cystic. So again, you're going to get some more disorganization with this malignant. So the risk factors: nulliparity, family history, germline mutations with tumor suppressor genes. This is going to be like your RB, your P53, all of those things that normally keep your cells from becoming cancer. Do you guys know what a protective factor for this is? So long-term birth control. The reason being that every time you go through ovulation, you being an ovary, it's kind of a traumatic event. And so the more times that happens, the more like trauma is being done to your ovaries. And so if you're on birth control, meaning you don't ovulate, or if you get pregnant a bunch of times, meaning for 9 months at a time, several times you don't ovulate, that's going to be protected, which is why nulliparity is a risk factor. Because if you never get pregnant, then you're theoretically ovulating every single month. And then what's the tumor marker for ovarian cancer? Yeah, shout it out. CA125. So one super important thing for that is that you cannot use that to diagnose it. You can only use it to track it and look at recurrence. So that's something that's tested pretty often also. You cannot use CA125 to diagnose ovarian cancer. That's actually one of the big problems with ovarian cancer, is that it's really hard to diagnose it until it's advanced.
Hey, Jack.
Yeah.
Is it possible to, like, I don't know how, like, the lights and the screen and the glare?
Yep.
And while we're at it, is there a way to turn up the mic? Love you.
Turn off the mic?
Up.
Oh, okay. One sec. Okay, that didn't do anything.
She'll get it.
Is that okay?
Yeah.
Yeah.
All right. Is that louder? Yeah. All right, cool. Okay, so other surface epithelial tumors. Endometrioid versus Brenner. So I would say like there are kind of three things I would know. I would know that endometrioid is P10 and unopposed estrogen. And this is going to be like the same as it is for other cancers. So the other endometrioids are also from estrogen and also P10. So that's just an association you know, and then it's going to be applicable to multiple things. And then Brenner, that's a transitional type epithelium resembling the urinary tract, so think Brenner bladder. So BB, Brenner bladder, it looks like bladder cells.
Excuse me, can you go back to the last slide? Yeah, I think you said that this was benign spirits, but it's actually benign users, not much.
Awesome. It's in the notes under the bottom of the slide. So, all of the pictures that I put in have things in the notes at the bottom of the slide saying what's correct, so I'm sorry, like I said, I didn't have as much prep time as I normally do, so thank you for pointing that out. All right. Okay, more tumors. Teratoma. So mature is adult tissue from 2 to 3 embryologic layers, so it can be like skin, hair, bone, cartilage, whatever. 90% of them are unilateral, and it's pretty rare for them to have malignant transformation. In women, it's only about 1%. Do you guys know what kind of cancer you get with these?
Squamous,
Squamous what?
cell carcinoma,
Squamous skin cancer.
that one, yeah.
So these turn into skin cells, and then you get skin cancer. Again, something that's like weirdly highly tested. Okay. Immature, primitive, the most common form of tissue that becomes is neural tissue, and you'll get necrosis and hemorrhage. All right, germ cell tumors, so dysgerminoma, radiosensitive is a big thing there. Solid, clear cytoplasm. You have to know the tumor markers. There's like no way around that. Come up with whatever memory trick works for you. For this one, it's LDH, and then in the male, that's a seminoma. Endodermal sinus tumor or yolk sac tumor is going to be the friable mass in the Schiller-Duval bodies, which are the glomeruli-like structures. And then that's going to be alpha-fetoprotein. So you can remember that's AFP because it's from the yolk sac, right? That makes sense. Yolk sacs make AFP, alpha-fetoprotein. Fetal is like the middle part of it. And then choriocarcinoma, those are the super malignant ones. Small and hemorrhagic. Again, it makes sense that it's hemorrhagic because the chorion is like the placenta, like little tissues with trophoblast and cytotrophoblast, no villi. So that's something that was pretty largely emphasized by Dr. Mirza. And then HCG, and again that makes sense because HCG is the pregnancy marker and this is the placenta. And then embryonal, primitive cells, it's like an embryo. Okay, what is this? Yeah, Schiller-Duval bodies. So it's an endodermal sinus tumor. So this thing right here is the thing that looks like a glomerulus. This whole deal. All right. So then the sex-port stromal tumors, granulosa has Call-Exner bodies, which are the gland-like structures, and the tumors produce estrogen, so they can cause postmenopausal bleeding. All right, and then Leydig. The big thing there is the Ranke crystals and the androgen production. So androgens cause virilization, so it would be like a woman who suddenly starts getting hair growth, deeper voice, all that fun stuff. Okay, and then fibromas. The big thing associated with this is the Meek syndrome, which is the pleural effusions and ascites. Okay, vulva. All right, so Bartholin cyst. Inflammation and obstruction of the Bartholin gland, which is the inferior aspect. It's mostly in sexually active women. It's going to be unilateral and painful. Complication of it is abscess, and it's treated just by like incision and drainage antibiotics. All right, I just scattered these questions randomly throughout the thing. They're not related to like the topics we just looked at. It's just to keep you guys awake. So go ahead and read this. No menstrual periods, galactorrhea, bitemporal hemianopsia. So those are the three things you got. So the no menstrual periods and galactorrhea tell you that it's prolactin, right? Because that's what's produced after you have a baby, and so it keeps you from getting pregnant and what causes you to produce milk. The bitemporal hemianopsia tells you that it's a pituitary tumor. So there are a bunch of kinds of pituitary tumors, and depending on which cell type the tumor is made of, it'll produce different things, and so this would be a lactotropic pituitary tumor. All right, herpes simplex. You're going to get it, it's sexually transmitted, so remember HSV1 is the oral, HSV2 is the genital. The symptoms, pain with urination, itching, painful intercourse, and the findings of painful vesicles on the erythematous or ulcerative veins. Did you guys talk about this unit, or you wait till next?
We talked about it.
Okay, great. Is this the unit where you did like the different types of sores on the genitals?
Yep.
Okay, cool. So condyloma lata, this is secondary syphilis. So it's obviously syphilis. It's only a little bit after the primary lesion heals. The primary lesion goes away. So you're going to get like the raised red lesions with the roughness, and then the condyloma lata is going to be in the moist areas, like in the skin folds. And you get lymphadenopathy, and sometimes you get fevers. So verrucous, warty lesions in the skin folds. That's gross. Okay. And then condyloma acuminatum. So make sure you know the difference between those. So this is going to be the low risk HPV types, and HPV 6 and 11. And these are going to be raised genital warts versus condyloma lata was like flatter warts. And like this HPV, it can be from sexual activity. 1 in 4 of HPV are like the warts that kids get on their hands. 6 and 11 are genital warts, and they're sexually transmitted. So they're genital or anal, and the key feature is this cell type that they talked about, the poilocyte, the like raisin nuclei or whatever. Yeah, right. All right, and then lichen sclerosis. So this is the like the thinning white parchment paper of the vulva. It can also happen on penises, but I believe you guys only talked about it in terms of vulvas. This is from chronic inflammation. It's going to cause itching, and it can cause pain with peeing, and pain with intercourse, because it like tightens the skin, and so it can cause pain when the skin is stretched with intercourse. And it can lead to squamous cell carcinoma. So this, again, another thing that was like largely emphasized by Dr. Mirza, lichen sclerosis does mildly increase your risk for squamous cell carcinoma. Lichen simplex chronicus does not. And the way that I remember this is, if you remember that lichen simplex chronicus is caused by scratching, it would be really weird for scratching to give you cancer, right? Like you wouldn't really think about that. So that's how I remembered it. So basically, it's just you scratch, you cause irritation, and it causes the skin to thicken. So you get thick, leathery labia and vulva, and it's totally benign. Paget's disease, malignant proliferation of epithelial cells in the epidermis, red, scaly, crusted, itching. So there are really just like 2 things you have to know about this. One is that it is not an indication of underlying cancer, which Paget's disease of the breast almost always is. I'd be very shocked if you don't get a question on that. And the other one is that the differential diagnosis for Paget's disease of the vulva is melanoma, and you differentiate them by cell markers. So, sorry, the text got messed up. The vulvar melanoma is the red box. The vulvar melanoma is S100 positive and keratin and PAS negative. And then Paget's is PAS positive, keratin positive, S100 negative. Okay, it's decreased TSH. So this woman has hyperthyroidism, right? So she would have an increased T4, but you're going to have a decreased TSH because TSH is regulated by negative feedback by T4. All right. Yeah, so I think you guys know this, but for pretty much any lady part cancer, HPV is the biggest risk factor. Including for vulvar and vaginal, HPV is a bigger risk factor than lichen sclerosis is. So vulvar carcinoma is not super common, but it happens. Vaginal carcinoma is extremely rare. rare. They're both in old ladies. They're both from high-risk HPV. And then for vulvar, you can also get it from lichen sclerosus. So the difference is that for the high-risk HPV, you're more likely to see that in like your 40s and 50s. The lichen sclerosus, you're more likely to see that in like 60s and 70s. The reason being that HPV takes, like, depending on what you look at, somewhere between 15 to 25 years to cause cancer. And so a lot of these women get it when they're younger and more sexually active, or have more sexual partners. So they contract HPV in like their teens or 20s. 15, 20 years later, it causes cancer, versus lichen sclerosis, you get it at an older age, like 60s and 70s. For all of these, the precursor is just whatever part you're talking about, intraepithelial neoplasia. Presentation, going to be leukoplakia for vulvar carcinoma, and then for vaginal, you get vaginal bleeding and discharge because you're going to get like friability. They both met to the regional lymph nodes. This is probably in there later, but I'm not sure. Do you guys know? So for the vagina, for the upper portion versus the lower portion, for the whole pelvic area, it's like test writers are super excited to ask you what lymph node stuff goes to. So for like lower vagina, that's going to go to inguinal, so like by your inguinal ligaments down here. For upper vagina, that's going to go to iliac. And then for the ovaries and testes, those go to para-aortic. The reason being they started like up here. Ovaries and testicles start up here, and so they're connected to the lymph nodes that are up here, and then during development they descend. Okay. So testes and ovaries go to para-aortic lymph nodes, which are like up here on either side of your aorta. The reason being that embryologically, your testes and ovaries develop in your abdomen, and then they descend as you develop. And first aid has like a pretty good diagram where everything goes, what lymph nodes everything goes to. Okay, so.
I didn't notice, but I'll probably.
Okay, so lower part of the vagina, inguinal, which are the lowest of the ones we're going to talk about. Upper vagina, iliac, and then ovaries and testes, para-aortic. So for HPV, you need to know the different types and what they go to. So like I said, HPV 1 through 4 cause verruca vulgaris, which is like the warts little kids get on their hands. I don't worry about that. Okay, condyloma acuminata, again, causes genital warts, 6 and 11. And then HPV dysplasia, your big risks are 16, 18, and then to a lesser degree, but still important, 31, 33. All right, vulvar carcinoma. Again, this is what we're going to talk about. It's from HPV or lichen sclerosis. Lichen sclerosis is going to be at an older age. Okay, so normal vaginal discharge, so not all vaginal discharge is a sign of pathology, basically, is just the point of that. Okay, did you guys do like BB, trichomonas, all that stuff this unit? Okay, great. New question. So medullary thyroid cancer is really different from any of the other types of thyroid cancer because it's a cancer of the C cells, to the calcitonin-producing cells, and so that's going to have the amyloid stroma with the Congo red staining. It's also going to be associated with MEN1A and MEN1B. The MEN syndrome. I think those are the ones. We'll go over it later. Okay. So you said you did not go over this? You did.
It was
Yeah, we did.
smaller. We didn't go over, but we're meant to know it. We're supposed to know it, basically.
Great. Okay.
Jacq, on the last question, aren't T cells found in the parent thyroid?
C cells are the medullary cells.
You're meaning they're parafollicular.
Oh,
Yeah.
here for Lindsay.
Yeah.
Okay, thanks.
Okay, so bacterial vaginosis or Gardnerella vaginalis. Personally, I would just watch the sketchies for them. I'm a big fan of sketchy, but basically the things you need to know: pH is over 4.5. It's going to be a fishy odor, which sounds gross. Thin grayish white discharge. There's going to be these things called clue cells, which are actually epithelial cells. And you can do the whiff test. So it has a fishy odor when you put potassium hydroxide on it. So KOH is what you put on that. Treatment for this and for trichomonas is going to be metronidazole. All right, so trichomonas, again, pH greater than 4.5, sexually transmitted. It's going to be, again, a gross smell, but it's going to be a yellow or green discharge. It's got this keyword of strawberry cervix, which just means the cervix is really inflamed. And you're going to look at a wet mouth, you're going to see modal trophozoites, so you just see stuff swimming around. Treatment is also metronidazole. The big thing with this, and the thing that they're going to ask you on a test, is that you have to treat the woman and her partner, otherwise the partner will reinfect her. So that's like the key for that one. So Candida is a yeast infection. So this is like the things you hear about of like people who wear wet bathing suits too long can get them. They're also increased in pregnancy, in immune-compromised states, and steroids, and diabetes, which is an immune-compromised state, and women who are taking birth control, and people who are on antibiotics. So basically, anything that causes immune compromise or that messes with your normal flora. It's a thick discharge, and it's very itchy. And the treatment is, there are several different treatments for it, but basically just look for an antifungal. So, yeah, just look for an antifungal. So any of like the azoles or like anything like that. Okay, cervicitis, did you guys do gonorrhea versus chlamydia?
Yeah.
Okay, great. So gonorrhea, is like the gram-negative. You get the Thayer Martin chocolate agar. It is encapsulated and it is intracellular inside neutrophils. They're both STDs, obviously. It has like the thicker discharge. Remember the sketchy had like that chandelier with the candle wax dripping off? So it's like a waxy, like almost candle wax. And then the sequelae of this are the Fitzhugh-Curtis syndrome. So the violin string adhesions is like the key word for that. And then you can also get pelvic inflammatory disease and asymmetric large joint arthritis. So in men, you mostly see the asymmetric large joint arthritis. In women, you see the other two. And then the treatment of ceftriaxone, the key for this is for either of these, you treat for both because they're so commonly co-infected. And it's estimated that I think a quarter of all sexually active women have chlamydia. Like it's incredibly common. For chlamydia, you do need to know the different serotypes. The sexually transmitted one is types D through K. I feel like you can probably see the memory trick for that. You got it. And then you need to know the two different types, so elementary bodies versus reticular bodies. So elementary enters, so that's the infective type. Reticular replicates. So EERR. Elementary enters, reticular replicates. And the other thing is like the L serotypes of chlamydia are the ones that do the tender lymphadenopathy. So L for lymphadenopathy, and then A through C are the ones that cause blindness. So A through C makes it you can't see. And that's like the number one cause of blindness in third world countries. So the big thing for this is friable cervix. So I've actually seen this in clinic where you go to do a pap smear, and when you do the pap smear, it starts bleeding. That's called a friable cervix. It just means it's really friable, falls apart easily. So that is a sign of chlamydia. I don't know why it says Fitzhugh-Curtis syndrome under there. That is not correct. The treatment is macrolide or doxycycline, and then, again, you would also treat for gonorrhea. And it's gonna be a clear discharge. This is also obligate intracellular, and it doesn't really gram stain either way. And you test for it with gnat staining, or gnat test.
Hey, Jack,
Huh.
what is on the last slide? What's under there, Martin, in that black letters that,
I have no idea.
it's what?
Oh, PBN, so polystatin, niacin, vanco. So it kills off everything else.
Which one does not have FITZU associated with
I've
it?
never heard of FITZU with chlamydia.
Okay.
Again, like, I got PowerPoints to do these that were based on like 2014 lectures, and so I tried to change them up with your guys' stuff, but again, this time I didn't have time to completely do it. So take it with a grain of salt. I'll tell you if I see anything that I think is wrong, but most of it, I'm pretty sure is right. I went through it. I just might have missed a couple things. Okay, vaginal adenosis. This is, so normally the stratified squamous, which is the lower 1/3, moves up and replaces the simple columnar epithelium. The upper 2/3, so the entire vagina is squamous. However, vaginal adenosis is when that does not happen. It's persistence of the columnar epithelium, and this happened to women who had DES exposure when they were in utero. And then this can lead to the clear cell vaginal carcinoma. And do you guys remember what the moms got? No, it's on there. Moms had increased breast cancer. So the DES was like a morning sickness drug, I think. Yep, from pregnancy complications. So the daughters got adenosis and clear cell vaginal carcinoma, the babies who were in utero at the time, and the moms had increased breast cancer rates. Okay, yeah. Okay. So fibroadenoma is like the most common in young women, right? It's benign. All right. Embryonal rhabdomyosarcoma or sarcoma botiff. You guys know how to say it. So it's really rare. It's in little girls under the age of 5. So it's a tumor of immature muscle cells. So the thing you're always going to see is a bleeding grape-like mass protruding from the vagina. And then the big thing here is just what does it stain for? It's going to stain for desmin and myogenin. Okay, we already went over this. All right, so vaginal carcinoma, extremely rare. It's going to be in older women. It's from HPV. This is what we talked about. The lower 1/3 goes to the inguinal nodes, upper 2/3 to the iliac nodes. Okay, cervix. So the endocervix is simple columnar. And then the ectocervix is like the squamous, and then you have the transformation zone in the middle, and that is where you're going to get most of your cancer. Okay, so the cervical squamous intraepithelial lesions, the risk factors, obviously the biggest risk factor is HPV. The other really big one that you have to know is smoking. So there are basically 2 cancers where smoking is a big risk factor where it doesn't make intuitive sense. And those are pancreatic and cervical. So the way I remember it is like cervix has like a little hole in the middle, so I just pretend like it's like smoking through the hole. And then the other risk factor is immunosuppression, which makes sense because a lot of women have this virus and you'll get cervical cancer from it, right? But if you're immunosuppressed, then the virus can wreak havoc and then you can get cancer from that. So because of that, it's what's called an AIDS-defining illness, meaning if you have HIV and you get cervical cancer, you are now classified as having AIDS. Okay. All right, and then do you guys remember how you classified CIN 1 versus 2 versus 3?
How deep
It's just like
it
the
is?
percentage of the depth. So if it only goes 1/3 of the way deep, it's 1, 2/3 is 2, all the way through is 3, like all the way to the basement membrane, through the basement membrane is like high grade or something. All right. Yeah. The other thing that Mears has talked about was if you have LSIL, are you more likely to progress or is it more likely to
Regress. You receive,
Yeah, it's more likely to receive, so it's not a huge deal. The other thing is, theoretically, if a woman is getting regular pap smears, she should not ever get cervical cancer from HPV because anytime they find any lesions on a pap smear, they do what's called a colpo or colposcopy, or they do what's called a leap, and they're basically like regional excisions of any cancerous or precancerous part of the cervix, and then if it gets to the point where it's like really bad and it looks like it's going to spread, they just do a total hysterectomy. So a woman getting regular follow-up and following the procedures that are recommended should never get cervical cancer. Okay. All right, serous adenocarcinoma. So a lot of the serous ones have seminoma bodies. Okay. So the only thing I would say about this that we haven't really talked about is the presentation. So postcoital vaginal bleeding is kind of a buzzword for cervical cancer. And then dyspareunia, painful sections are kind of along those same lines. All right, so the endometrium. The requirements to diagnose endometriosis, we have 2 of the 3 of endometrial glands, endometriostroma, or hemosiderin pigment in extrauterine tissue. You guys know endometriosis is endometrial tissue, places where it's not supposed to be. In the ovaries, you'll often see what's called chocolate cysts. Symptoms of this are going to be severe dysmenorrhea, pelvic pain, and pain with defecation or urination, and that's just going to depend on where it is. So this tissue grows cyclically, right? So it's going to grow and then it's going to shed when the woman is like on her period. So if it's like against the bladder, then it's putting pressure on the bladder, it can give you pain with urination. If it's going against the colon, then it can give you pain with defecation. What's adenomyosis? Yeah, it's like endometrium and the myometrium. And then leiomyoma. So that's a benign tumor, and it's estrogen responsive, so they're also called fibroids. So they're basically just these giant collection of tissue in the uterus, like in the wall of the uterus. And so if you like palpate the uterus, it'll feel really lumpy. On histology, they have a whorled appearance, and they're very well circumscribed. And huge point, he emphasized it a ton, is these do not become leiomyosarcomas. So leiomyomas and leiomyosarcomas, same tissue type, one is benign, one is malignant, one does not lead to the other. Okay, endometrial carcinoma, you need to know the 2 types, endometrioid versus serous. So endometrioid comes from endometrial hyperplasia. It makes sense this comes from estrogen, also just E and E. So anything that increases your estrogen is going to increase your risk of this. So obesity increases estrogen because adipocytes make estrogen. Obviously, like exogenous estrogen, so some women take this to treat menopausal symptoms. This used to be used for like some types of cancers. Used to be used for osteoporosis treatment and prevention. Early menarche because it just means you have estrogen, for, like higher levels of estrogen for a longer amount of time. Late menopause, same thing. Diabetes, hypertension also are increased estrogen. And then anovulatory cycles increase your estrogen. This is usually in women who are about 60. Histology looks like an endometrium, and then P10 mutations. And I just remember that that's endometrioid because it has an E in it. And then serous is sporadic, so there's not a precursor lesion. So endometrioid, the precursor is the hyperplasia. Serous, there's no precursor. It's a little bit older, but I wouldn't really worry about that time difference. And then serous is all S's and P's. So serous, sporadic, papillary seminoma, P53. So it's all S's and P's. You just have to not use that rule for the P10. P10 has an E, it's endometrioid. All right. You guys better get this. I literally copy and pasted this slide from Dr. Mears' PowerPoint. probably didn't get it in lecture, and then he got really annoyed. That's what happened with us. Okay, adenomyosis, good job. Okay. Abnormal uterine bleeding, so the acronym that's used a lot is POMCOIN, so look that up if you feel so inclined. This was the organization that Dr. Mirza did, which was pre-puberty. It's going to be from precocious puberty. Adolescence is usually from an anovulatory cycle, because the woman's body just hasn't quite figured out that whole ovulation thing yet. Reproductive, it's either going to be proliferative or it's going to be a complication of a pregnancy. Perimenopausal can either be an anovulatory cycle because the woman hasn't figured out how to be menopausal yet, or it can also be proliferative because that's when a lot of the cell cycle regulators stop working. And then postmenopausal is either going to be cancer, hyperplasia, or polyps. Okay, so acute versus chronic endometritis, what's the main cell type for each? So same thing for any infection, right? Acute is going to be neutrophils, chronic is going to be lymphocytes, and then what is the symptoms? So again, any infection, you're going to get fever, you're going to get pain at the site of the infection, and then in this case, you're going to get menstrual changes, and that can lead to an infertility and ectopic pregnancy. Okay, there's the male germ cell tumors, so seminoma, very radiosensitive, the large cellular cytoplasm, embryonal, necrosis and hemorrhage, large anaplastic cells, and then yolk sac, same as the other one, Schiller-Duvall bodies. The difference is that this is really common in baby boys, which I think is probably worth noting. Choriocarcinoma, again, it's like a placental tumor, so highly aggressive, it's going to be really hemorrhagic. And then teratoma, this is another thing that's super highly tested. So in women, teratomas are almost never malignant. In men, they're much more likely to be malignant. Okay, and then the male sex cord stromal tumors, again, Leydig, the Ranke crystals are the big thing, and then Sertoli, fried egg nuclei. It's really highly tested. Okay, and then for the different types of pregnancies, so for twins, which type of twinning it is going to be dependent on the day of when they separate. So if it's in the first 4 days of gestation, you're going to get dichorionic, diamnionic, and both of the top two are that. If it's in days 5 through 8, you're going to get monochorionic, diamnionic, 9 through 12, monochorionic, monoamnionic, and then if it's day 13 or later, you get conjoined twins. Okay. Yeah, so it's just sets of 4. So first 4 days is di-di. Next set of 4 days, so 5 through 8, is mono-di. 9 through 12, mono-mono. And then 13 on is conjoined twins. Okay. Another thing super highly tested is the moles and the differences between them. So you need to know the difference between a complete mole and a partial mole. So the complete mole is going to be 46XX or XY. Partial mole is triploid. So the complete mole has a lot more trophoblast proliferation. It's much more likely to have atypia, and the serum